Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, MARKUS HOMe welcomes Dr. Sandra Herrmann in Rochester, Minnesota, with whom we would like to discuss immune checkpoint inhibitor-associated nephritis, which is the topic of a recent treatment standard paper in Nephrology Dialysis Transplantation, which NDT's editor-in-chief, Dr. Anders, Andreas Kronbichler, and I picked as our NDT paper of the month for a full-length MARKUS HOMe discussion. Sandra, thanks so much for being our expert this European evening, American morning, for an update webinar on this highly important topic after our previous 2022 discussion. Dr. Herrmann is professor for nephrology at Mayo Clinics in Rochester. The focus of her clinical and academic work is the field of onconephrology, and she has published many relevant papers on renal side effects of immune checkpoint inhibitors, including a very recent position statement paper from the American Society of Onco-nephrology on diagnosis and management of immune checkpoint inhibitor-associated nephrotoxicity with Dr. Herrmann as first author. And also for the second time, we welcome Professor Jörg Bittenbrink as our guest editor. Jörg Bittenbrink is oncologist, hematologist, and professor of internal medicine at the Saarland University Medical Center in Hamburg, Germany. And he has been our guest before when we had Dr. Malishko and Dr. Karem as guests. So thanks so much to the two of you. Welcome back. Now we are excited to hear from you on your recent data.
Thank you for having here and present our most recent review at NDT and also some data from the position statement and what is the up-to-date in this area. It's a topic that's I'm really enjoying working with, treating patients, also studying further. I have no disclosures regarding this topic, and as a learning objective, I'd like to review the nephrotoxicity of the ICI therapy. We're going to review a little bit about the pathophysiological mechanisms and clinical pathological features of ICI AKI, and we'll discuss what the clinical practice points for the initial assessment and diagnosis, management, immunosuppressive therapy. We're going to discuss a re-challenge with ICI following AKI episodes as well. So I just would like to start with a case because this is a common patient that we see on a weekly basis, if not more than that. It's a gentleman with 60-year-old treatment with diagnosis of metastatic colorectal adenocarcinoma, returning for his third cycle of pembrolizumab, pemetrexed, and carboplatin. During the oncological visit, he was found to have acute kidney injury. Creatinine is elevated from 1 to 3.4. And in terms of past medical history, he just had a history of hypertension, GERD disease, and it was in typical medications such as amlodipine and omeprazole. The oncology physical examination, they had just mild trace edema, but otherwise unremarkable, and patient was not feeling anything. However, the laboratory, as you can see here, showed the patient had some trace anemia, mild hyponatremia, acidosis, and as discussed before, the creatinine had increased significantly from his baseline. And also show here some biomarkers that we use, and I'm going to discuss later about the inflammatory state of this patient. The CRP is elevated, and also urine retinol bind to creatinine ratio is significantly elevated, as you can see above 11,000. So in this case, you might think, what's caused the kidney injury? We have only 3 drugs that easily can cause nephrotoxicity. And if you can say pemetrexed and carboplatin, you probably have a higher incidence of cause nephrotoxicity than pembrolizumab. In this case, can you say for sure what's caused the acute kidney injury? I couldn't. So in this case, we're usually not sure, and many times we will recommend kidney biopsy if patient doesn't have contraindications. So as there is so many drugs that can cause nephrotoxicity, especially in the cancer area, you can see those 3 drugs, they most commonly cause tubular injury in these patients and leading many times to AKI. So that comes the point of our topic here. I'm going to talk about the checkpoint inhibitors, which are really drugs that revolutionize medicine. And as you can see here, has been using for almost any type of cancer. And they have been started with initial CTLA-4 and PD-1 inhibitors, but most recently we have new checkpoint inhibitors, which the LIG-3 inhibitors that used mostly for treatment of melanoma, and they be treated with another checkpoint inhibitor, usually a PD-1 inhibitor, nivolumab. So as you can see here, these drugs are being broadly used in the oncology area. However, how those drugs, the discovery of these drugs led to the Nobel Prize, and also the mechanism that they work for the treatment of cancer is quite interesting. You can see that ICI, they disrupt the normal immunoregulatory checkpoints. In this case, I'm showing here the checkpoint 4 and the PD-1 blockade. One is mostly the CTLA-4 occurs mostly in the lymph nodes and other more in the periphery. And the peripheral one is mostly used that the tumor is used to evade the immune system. As you can see here, if the immune checkpoints are able to do what their function, they keep our immune cells deactivated. But when you use the checkpoint blockade, they activate the cells and they can act against the tumor cells. This is fantastic, and that's what we would like for the treatment of the cancer. However, when you unleash the immune system, especially with the new immune checkpoints, you can cause adverse effects. In the case of immune checkpoint inhibitors, we call immune-related adverse events. And as you can see here, you can have adverse effect in any part of our human body, our systems. Most commonly, systems affects the GI and the skin tract, but any type of organs can be affected. The incidence of immune-related adverse events from ICI therapy can be as high as 80%, and many patients have at least a kind of fever or some symptoms that they can relate as adverse event. What is pertinent to the kidney here, we can see that the incidence of immune checkpoint-associated AKI can be up to 5%, especially when used as a combination therapy. From the clinical features, what you see in this patient when they develop AKI, that the most common type of lesion found in the kidney biopsy is interstitial nephritis. And as you can see here in a previous retrospective study, this is followed by acute tubular necrosis, which is another type of lesion that you can find in these patients. But particularly, I don't think this is complete and direct effect caused by the immunotherapy. This occurs usually around 12 to 16 weeks after initiation of ICI therapy, but this can occur even early, even a couple of weeks after. I've seen patients with the dual blockade therapy and they develop AKI and also other immune-related adverse events. Most of the time, those patients, when presented with immune checkpoint-associated AKI, they have a history of a previous immune-related adverse event, or they also have at the same time another IRE, such as colitis, a skin rash, or something related to the immunotherapy. What we know that nearly 50% of those patients will develop stage 3 AKI, and of these 16%, 80% overall, you require some type of renal replacement therapy. Those patients who develop the ICI AKI, though they usually have some risk factors, which include AIN drugs, most commonly PPIs and NSAIDs. Those patients usually have a lower baseline GFR, which may not be related to the fact of have a lower GFR per se, have more immune-related adverse event, but just because you have a low reserve, and most likely you're going to find out or develop some type of AKI. Prior immune-related adverse events also puts the patient at the risk of develop ICI AKI and the combination therapy. I'd like to point out that there's a lot of discussion in terms of PPI being associated with the risk of developing ICI, AKI, but we don't really know in a prospective manner because 60% of those patients, when we review our patients here, they were on PPI therapy, but not everyone developed. But when we did the systematic review, we know that almost those patients who are on PPI therapy have almost twice as much chance to develop ICI-associated AKI. And the mechanisms, we don't know for sure if this is related direct to tox damages from the PPI, locally formed haptens, or haptens that are metabolized by tubular epithelial cells. And so these dendritic cells present to the T cell that will lead to activation and then cause the possible release inflammatory cytokines, development of ICI-ANN, and then all the consequences that a patient who develops AKI have to deal with. So ICI-ANN is the most common side effect of these patients. But they also can cause other type of renal or electrolytes and acid-base disorders in patients who are taking ICI therapy. Most commonly, what we see, and then in any type of cancer, patients develop hyponatremia or hypokalemia. And the mechanisms can be different types, could be just because patients have diarrhea from colitis, could be endocrine cause, but studies have shown that endocrine direct related causes are very minimal. That would most likely is related to some other phenomena, but not related to endocrinology causes. Other electrolytes abnormalities or minerals are hypercalcemia, hypocalcemia. They can cause hypo or hyperphosphatemia. Hypernatremia, also not uncommon, especially the patient might be dehydrated. But a phenomenon that I like and I think is very interesting to be pointed out here is the phenomenon of renal tubular acidosis. In our group, we have reviewed kidney biopsies of patients who develop renal tubular acidosis, and we found that typical annual exchangers or that are part of the VATPAs, they are in the intercalated cells. They have their expression decreased in comparison to the patients' controls, which are kidney biopsy of donors for a kidney transplant. You can see here that most of the time they have some degree of inflammation, but the expression of this VATPase type of channels are decreased. So this is the same phenomenon that occurs in patients who develop Sjogren's syndrome and have, for example, interstitial nephritis and have RTA because of the autoimmunity. It's very similar, so it's a very interesting cause of RTA. The other type of pathology that we can see in patients who are on ICI therapy are glomerular pathologies. Most commonly podocytopathies like minimal change disease and FSGS and pulse immune vasculitis, which in this case, they are the most common pathology seen in patients with the glomerular pathology due to ICI therapy. So those are the clinical pathological findings that you find in these patients. But what do you do for the diagnosis? The diagnosis of ICI therapy related AKI is mostly found out by the oncologist. And then once the patient develops AKI, they send it to you. When they send to you, what you do to diagnose or do a further workup, we usually recommend the patients have a completed workup to see a chemistry panel that includes albumin, so we can find out the patient has nephrotic syndrome. We can look for urine analysis with protein to creatinine ratio. And also, here at Mayo, at least we have this available. We do order C-react protein or CRP and also check urine retinol bind protein to creatinine ratio. And most recently, a few years ago, we also tried to work up with a full cytokine panel that includes different types of cytokines in the serum. Other imaging studies are very important because these patients with cancer, we want to rule out they have obstruction, so a basic ultrasound of kidneys is important. But sometimes the patient comes for oncology and they have a PET scan that can be useful, and I'm going to discuss a little bit about some studies using this for the diagnosis of ICI-AIN. But the gold standard ultimately it's kidney biopsy. But unfortunately, a lot of times those patients cannot undergo kidney biopsy because they have some contraindication. Most of the times they might have had some DVT and they are on anticoagulation, which makes difficult for the biopsy. So the major barrier for us to diagnose of ICI, in the case most common pathology ICI-AIN, is the diagnosis and the lack of non-invasive tests. So I'd like to go a little bit about what those biomarkers and how they can be helpful. In our group here, we did a retrospective study where we look about these biomarkers in patients. We had biopsy-confirmed acute interstitial nephritis or presumed acute interstitial nephritis versus those who had other pathologies or did not progress to kidney injury. We deemed them to have non-ICI AKI. We found that those patients have significantly elevated CRP in comparison to those who didn't have ICI-AIN, and also have a much higher elevation of the urine retinol bind protein to creatinine ratio. You can tell me that when you do the log of the CRP and the urine retinol bind protein to creatinine ratio, those with the ICI-AKI had a much higher levels of the log of these two markers in comparison to the others who didn't have higher markers. However, patients with acute tubular necrosis per se can also have higher urine retinol bind protein to creatinine ratio. Not always they're going to have elevated CRP, but they can have. So the caveat with this test that they are not very specific for ICI-AIN, but they can be helpful. To me, they are mostly helpful when they are negative, because I don't know in your practice, but in our practice, we get calls from oncologists who say, I have this patient with creatinine is 0.09 milligrams per liter, and now it's 1.3 milligrams or 1.4, and they are doing well. I think they are a little bit dehydrated, not drinking so much. They are very helpful for me when I order those biomarkers, and if the CRP is normal and the urine retinol bind protein to creatinine is normal, they didn't have a full AKI to cause ATN or things related to that process. There is an intrinsic process in the kidneys. They most likely do not have ICI-AIN, and then I can say, okay, just give some fluids, we check labs 1-2 days and see if they're okay. And many times, our patients came from far away, so they can do that, and they check next day. Obviously, serum creatinine is improved, and also the biomarkers are not elevated. They can go ahead and give the ICI therapy without waiting for, a biopsy or something like that. It's very important to also notice that patients cannot be immunosuppression if they already have an AKI and they are taking prednisone because of some colitis, pneumonitis, or some other immunorelated adverse event. The CRP, many times you'll be within normal limits. Obviously, with a more significant AKI, the urine retinol bind protein can be elevated. So you have to be very careful when you make the diagnosis. So many times you have to send the patient to the kidney biopsy to really find out what's going on. There are some other biomarkers that we have looked at. There is a group from EAO that have found out that TNF-alpha is elevated in patients with ICI-AIN, and we also showed this in our patients who have ICI-AKI. And those patients who have AIN, they have elevated as compared to patients control without AKI, and also as compared to other patients with AKI that have other causes like ATN, for example. So this is not validated, but it shows that TNF-alpha is important for the mechanism of AIN, and in our case, ICI-AIN. We also haven't showed that important T cells are involvements for the mechanism, and we did a kidney tissue immunophenotype. We showed that the CD4 memory cells, T helper cells, And obviously, the dendritic cells, which are the antigen-present cells, are significantly elevated as compared to any other type of injury that's not related to the ICI therapy and obviously to controls. There is a really broad search for possible biomarkers that can help for diagnosis of ICI-AIN. We can see here in blue that those are clinically available, at least here we have available for urine retinol bind protein creatinine ratio, serum CRP, and also in the cytokine panel, we can have the soluble interleukin-2 receptors that can be also elevated during the ICI-AIN. The caveat for these two biomarkers that they're going to be elevated with if the patient have other immunorelated adverse events, such as pneumonitis, colitis, they also be elevated. More recently, again, the Molodino group has shown the urine CXCL9 has been elevated in patients who have interstitial nephritis. In their cohort, they have just a couple of patients with ICI therapy, but most likely this could be another biomarker that can be helpful for the diagnosis once it's validated. Talking and change a little bit to imaging studies, I want to discuss about PET scan for use to diagnose ICI-AIN. We had shown previous reports that a patient who initially had the PET scan done prior to initiation therapy, in the moment he developed AKI, you can see that FDG capture is enhanced and increased, but after resolve the process of the AKI, this is improved significantly. We did participate in a multi-center retrospective study where we look at this PET scan imaging patients who have ICI-AIN, and we contributed from 2 of the 9 patients that had ICI-AKI in comparison to other patients. It was a multi-center study with 53 patients that was conducted, and a total of 9 patients with ICI-AKI, in the case have interstitial nephritis, 24 with the non-ICI-AKI that were using control, but unfortunately, this was a cohort that was used for control, and none of those patients was an ICI therapy, and they compared to 20 patients who had ICI-treated patients but had no AKI. We can see that among patients with ICI-AKI, the SUV mean increased by a median of 57% from the baseline to follow up. And among patients with non-ICI-AKI, but the caveat, they were not on ICI therapy, increased by only 8.5%. So although this data suggests the PET-CT could be a useful help for diagnosis of ICI-AKI non-invasively, larger studies are needed to confirm these findings before we really use and can be endorsed. Because, just the fact of patient have AKI can enhance the FDG capture. So the accuracy of this measurement is complicated by several confounding factors, including the time of the FDG injection, burden of metastatic disease, and take up the FDG, and the dose injected, and the fasting stage. So it can be useful, but it not can be substituted, obviously, by the kidney biopsy. So kidney biopsy is important. When should be considered? If no contraindication, biopsy should be considered for evaluation of alternative etiologies of AKI, especially in the cases as our patient that I described earlier before. If they have a different type of nephrotoxic drugs, it's very difficult to say at this moment which one's causing, even though you can have some idea. If the patient have increase of creatinine by 1.5 to 2.0 baseline, we usually recommend to hold the ICI therapy and, see for other alternative cases and try to do conservative management with IV fluids and recheck in a couple of days if the AKI is severe. If it's mild, you can wait more days and see if the patient's improving with holding the ICI therapy. But if the creatinine continue to increase or not really improve, we would recommend to biopsy. And these are what we really delineate in our position statement paper. Also, those patients who have more moderate to severe AKI, we strongly consider kidney biopsy if there is no obvious case. And for some types of AKIs, they're milder and they're linger there with grade 1 AKI, but they have presence of renal tubular acidosis, or they have full nephrotic nephritic syndrome way in the urine analysis that's really active. I think you should consider the kidney biopsy as well. So once you make the diagnosis, how do you manage the patients with ICI, AKI? Obviously, you remove any culprits, include the ICI therapy, PPIs, NSAIDs, or any nephrotoxic drugs. For the patients who have more severe acute kidney injury, like grade 3, I would recommend start with some steroids to really get the treatment going. You don't need to do more 1 to 2, at maximum 3 doses, but usually I give 1 to up to 2, depends on the situation, and usually followed by slow taper of steroids. In our position statement, it could be very variable, the treatment and the length. I think if it's acute, usually we are able here to biopsy patient. Next day you have the kidney biopsy. I have really hard time to really taper the patient with a short-term therapy. So I usually go 8 weeks therapy. The steroid dose can be 0.5 to 1 milligram per kilogram dose. And that gives a good treatment, start with 60 and taper into 0 by the end of 8 weeks. It's important that the prophylaxis for PGP is initiated, especially for those patients who are getting like long treatment, like 8 weeks, because the recommendation for the patients above 4 weeks on corticosteroid therapy you would use. And I recommend pentamidine because Bactrim can also cause AIN. GI prophylaxis, if the patient needs to be on kind of prophylaxis, we recommend to use a H2 blocker such as famotidine. And discuss a little bit about the short course corticosteroid therapy. There is a retrospect study that they showed that patients could be tapered at 3 weeks versus 6 weeks therapy. However, most of these patients didn't have approved ICI, AKI in the biopsy. And it's very hard to say if it really was just ATN and then resolved per se. And to really convince and say these patients will need you'll be able to taper down the prednisone for short terms. I think we would need a randomized controlled trial with proven kidney biopsies, because most of my patients, they do need over 4 weeks therapy for sure. For the exploratory cases, we can use other type of drugs. Rituximab, interleukin-1, 6, MMF have been used, but TNF blockade are the ones that we have more experience for those who have more refractory disease. We have a recent show, as you have alluded before, the NED paper, that we show how we manage these patients with nephrotoxicity of the ICI therapy. We usually start with a dose of prednisone that's close to 1 milligram per kilogram. If you do 60 milligrams, you can taper 60, 50, 40, 30. By the end of 4 weeks, I review them in the outpatient. If the patient is not, rebounding, creatinine increase, they continue taper by 15, 10, 5, and then they do a course. And great majority, 90% of the patients do find they don't need any other type of sparing therapy. If they need some other therapy, this previous study has shown that infliximab for ICI-AKI had been used successfully for the management. The only issue here that they had, I have to say that they use very early in the course of the therapy. They usually taper the prednisone on 3.5 weeks, which really is a short term. And many countries, they do not have accessibility to infliximab as we have. So I think I usually do that if patients fail or start to rebound, creatinine increase significantly by the time of 4 weeks of therapy as you taper, or by the end of therapy, they start increasing. After that, I might consider using infliximab. And as an example here, I would like to show one of our biomarker guiding infliximab therapy for immune checkpoint associated acute kidney injury. We had this patient who developed interstitial nephritis. As you can see in red, the creatinine was quite elevated, initiated therapy, and nicely improved. But by the end of 4 weeks, the patient was just dropped 30 milligrams to 20 milligrams of prednisone. The creatinine have rebounded from 1 milligram to 3. At the initial, she was almost with 7 milligrams of per deciliter of increased creatinine. But because the patient, we knew that would be hard to or need long-term steroid therapy, we give a dose of infliximab, and we treat it for a couple more weeks of prednisone, just 20 milligrams and 10 milligrams, and it can completely suspend the therapy at this point. And as you can see here, after you give prednisone or infliximab, you can see that in this case, urine TNF-alpha nicely came down and show that patient was recovering. We didn't measure at the serum TNF-alpha, but this was already at the time when the patient was resolved therapy. You can see here that urine retinol bind protein and the CRP levels also can be nicely decreased and continue to decrease after the end of therapy. And we also measure CXCL9 here that was initially high and then nicely come down. So I think the biomarkers in the future will be very nice to guide the management. And also, even though urine retinol bind protein to creatinine ratio might not be very specific, it's very nice to help to see that the patient is improving and they can rebound if the patient have rebound increase of AKI as well. So that's how we usually manage ICI-AIN. For other type of pathologies like glomerular or vasculitis during the ICI therapy, mostly the treatments, there is no great data about that, but there's some case series that patients have required specific immunosuppressant therapy. Most of the time, the patients respond well to corticosteroids. The patients that I've had corticosteroids have been quite helpful. But other, such as post-immune vasculitis, some cases patients have responded to cyclophosphamide or rituximab, present mostly with partial or some complete response. So glomerulopathies can be treated, but are more directed and patient individualized medicine done type of therapy. Rechallenge to finalize in the past was considered, not recommended, at least by the ASCO NCCN guidelines, but we know this has been changing, and this year there is a new guidelines coming, and there's been changing how we're going to manage these patients. But we all know the patient, if they develop ICI stage 3, once they resolve the AKI, we can rechallenge those patients. In the largest retrospective study, approximately these patients did a rechallenge under low dose of corticosteroids, and only 1 out of 5 patients developed ICI-AIN after that. And you can see here, most patients did well, with just a minority of the patients had recurrence of AKI. In generally, when I do rechallenge the patients are very fresh from the AKI, like 2 months, and the oncologist say we need to restart. I usually use a low dose of prednisone, 10 milligrams daily at the first cycle, second cycle, and then try to taper off. This is particularly good if patient had a culprit, and in generally we just do a low dose of prednisone just to get the first few cycles, and they do well. For those patients who are like, they develop ICI, AKI, and the oncologist decide not to give more ICI for a period of time because the patient continues remission. If it's 5-6 months after AKI, sometimes you don't need to give prednisone. You can just try to go straight for the rechallenge with the ICI therapy. It can be the same type of ICI, or if the patient was a combination, the oncologist will decide which one will be discontinued and which one is going to be maintained. Recently, in our position statement, we have algorithm to delineate how we do the management of this patient. And for rechallenge, the patients with ICI-AKI should be considered for ICI rechallenge following stabilization of kidney function in a shared decision-making after discussing with oncology, nephrology, obviously the patient, and discussing what are the chances of response to the treatment, and also what are the preference by the multidisciplinary team. I would like to conclude this with a few points. The treatment of ICI-associated AKI is a multidisciplinary approach between nephrologists, oncologists, pharmacists, and also shared decision-making with patients. This is very important. It's important also that oncologists refer patients who develop AKI, even if it's mild, it might be a phone call away to discuss with the nephrologist. And also, it would be great if the oncologists, if they notice that some electrolytes abnormalities, especially if it's RTAs or have UA abnormalities, to consider referring to nephrology. Kidney biopsy should be considered for appropriate diagnosis and management, because such in the case of our patients, I have the same case patient who had platinum therapy, was doing fine for different cycles, and the biopsies just show ATN. We didn't necessarily, or the oncologist didn't necessarily interrupt the ICI therapy and maintain, and just to stop the other potential causes of nephrotoxicity, such as platinum or pemetrexed. It's important to note that most patients, the great majority, will respond to corticosteroid therapy, especially in the world that not many people have access to monoclonal antibodies such as infliximab. So if you do a prolonged term, sometimes it's enough to get patients to their baseline creatinine, especially if you get this right away. Glomerular disease will require specific immunosuppression treatment, and rechallenge has been done, and especially in appropriate setting has been done and works very well. Just before to finish, I'd like to get your attention for ICI or different immunotherapies we have been presented as being very difficult to keep up with oncology. There are so many new therapies that are coming up. I'd like to present this case. We have a patient who happened to have, very unlucky to have two kinds of cancers, who had the multiple myeloma and head and neck cancer. He was doing very well with the head and neck cancer treatment for approximately 3 years with nivolumab. After that discovery, had multiple myeloma, had a stem cell transplant, and was responding well, but then recurrent multiple myeloma, and he received bitherapy, which is used for refractory recurrent multiple myeloma. And patient was doing fine the first few weeks of the escalation of this bitherapy, in this case was teclistamab, had some cytokine release syndrome with mild elevation of creatinine. But then, even after being 3 years of nivolumab, getting prophylaxis with Bactrim because of the myeloma for 2 years, being on PPI for 3 years, after he got bitherapy, which is another immunotherapy, his creatinine started increased. And actually, he was getting some lower dose of dexamethasone. Creatinine was not changed. And we are consulted to see, is it the multiple myeloma, but the light chains had not changed much? Or is this some other type of cause? So we biopsy the patient. We gave, because the creatinine was going quite high, give a dose of methylprednisolone, which he responded after not respond to dexamethasone. And then the biopsy came showing interstitial nephritis at the end here. So I think the more we get these new drugs in the market and the combination of immunotherapies, we can see those might trigger the patient to develop immune checkpoint-associated AKI. BITE therapy is a new drug, and we know that we just recently showed at NDT that those patients have high incidence of AKI events. We didn't have a power to show that was significant statistically, but if you get more patients, we're going to have. So I think we have to be very careful, and the more new drugs come out, you have to be very attentive. Thank you for your time, and I'll be happy to answer any questions.
Thanks so much, Sandra. And now we leave the mic to our oncologist.
Yeah, thank you very much for this comprehensive talk about ICI-induced acute kidney injury. Maybe I start with a question for the patient. So usually we have patients with metastatic disease, and this kidney dysfunction came late onset, like 12 weeks in treatment. Usually, like a platinum toxicity would come early, as I would think. Patients having maybe dehydration or have less kidney function than we expect, and we give a first cycle of carboplatinum, and then we get a kidney dysfunction. This is what we usually see. And in your case, this was later on. So can you say that the late onset kidney failures are more prone to be ICI related, or is it because it takes some time to develop? I think.
Yeah, you're completely right. We would expect the platinum or pemetrexed to occur earlier. And they are much more common, like 20-30%, depend on the case. However, the platinum can cause damage. Some patients will not have AKI right away, but then later on, for some reason, they develop AKI. And even though this case you might think, most likely would be the immune checkpoint inhibitors, I did have case that was essentially platinum therapy, because I would say it was more, the biopsy was ATN. Some of those patients, because obviously I'm fortunate to have the biomarkers, they were not that elevated or at all. And biopsy the patient, we just found acute tubular necrosis. Discussing with the oncologist, we decided that he would just remove the platinum therapy, and once the kidney function back to baseline, he would continue ICI, and the patient did and had no problem. Even though you were totally right, you would expect earlier. I think it depends on the patient when they get more, sometimes poor oral intake, and the platinum stays in the kidney tissue for forever, I would say, or at least some biopsy we have done using imaging mass cytometry, we can see the platinum is still there, and for months it still can cause the damage and induce tubular injury. So I would not completely exclude being a platinum as well. And so in this particular case that I show in the others, when the CRP is not significantly elevated, patient obviously not taking prednisone, I'm more, I ended up biopsying just to see if it was ATN, and then I would not call this ICI-induced injury, for example.
Okay, my question is because it's always about reversibility. So if you may miss this late onset ICI-related kidney injury, and you don't give steroids early on, so I would think that the earlier the better. So if we miss these kidney dysfunctions, that would be bad. And so would you recommend to say, or would you say that in late onset kidney failure, we should be more easy or more ready to take a course of prednisone instead of, or if you don't have the resources to do biopsy?
Yeah, I agree. If you don't have the resources, I think you have to go and try to treat with prednisone and see if they resolve the issue, because ICI is such a great therapy. I don't want to label the patient, okay, this is ICI, AIN, and then, you are off of the medication, at least for some cases forever, some cases, okay, we're going to put down the treatment. But if you can find that the real cause is not related to ICI, then you can keep that therapy. The only reason I would suggest the biopsy to keep the patient in the most appropriate therapy, if you agree. And many of our oncologists, they do want to keep the ICI for certain types of cancer, obviously.
Yeah, that's the next point I want to ask, because 50% of rechallenge, that's quite a lot. If we look at other complications like pneumonitis or hepatitis, we would reject this, or we would say that patients who had such a life endangering ICI-related side effect, they would stop therapy. And we know that patients having such side effects get the full profit or benefit of the oncological therapy. So 50% of rechallenge, it's much more than in other complications. Actually,
I mean, 50%. Actually, we have like less than 20% rechallenge. 50% got prednisone in our.
okay.
Sorry if I was
so it's
not
only
clear.
20%.
It's one out of 5. Like it's a little bit less, depending of the study, like 17, 19. We'll have AKI, but usually the AKI they get if you treat again prednisone, they can go back if you were, on the top to the baseline GFR. Because kidney tissue and function is important for next treatment, whatever chemotherapy the patient may need to receive. So I think it is still okay to do the rechallenge if it's 1 out of 5 patients.
1 out of 5 only. Okay.
And usually, at least myself, unless it's really like emergency, wait till the patient get the kidney function as close to the baseline as possible. And in general, because immunotherapy lasts so long, they can wait a few months and to resolve the case. And they can do this rechallenge. Usually, the problem that I see when the patients are rechallenged because ICIN, especially if you do a low dose prednisone, is not much the kidney. The problem that they start getting other type of immune-related, like pneumonitis or colitis that they didn't have before, or if they had, usually the kidney is not an issue. And for the patients who really want to be alive, the good thing, obviously, we have dialysis. We can always put the patient on dialysis, different from the liver or heart. That it's a no.
In most severe cases, yeah. Okay. Good. So that would be my questions for the first.
I have a question to the two of you, actually. So do PPIs also contribute substantially to other forms of side effects of ICIs, or is this something particular to renal side effects? And would you, as oncologist, particularly recommend us to avoid PPIs and maybe also NSAIDs as far as possible, and rather to give histamine receptor blockers instead of PPIs in people who receive ICIs before they have any complications? That would be my first question. And the second question from a European perspective. So we do not have retinol binding protein in our regular lab here, neither in Austria nor in Germany. So it is just a tubular marker, a tubular damage marker. Could we also go for alpha-1 microglobulin or something like that? Or is there something else behind this retinol binding protein?
From the retinol binding, you could use another markers. We do use here in our hospital most retinol binding, but often could be potentially one. I have not done studies on that, but potentially could be another marker. Regarding the PPI and other immune-related adverse events, it has been associated with others and colitis, and also some studies have even looked at outcomes that potentially those might be implicated in worse outcomes and patients will be on a PPI therapy. Obviously, those are most retrospective studies, or there's some systematic reviews done this, and especially with the colitis type of issues. But, retrospectively it does have an association, but I think what we would be interested to be this prospectively, because the patients, they do need to be on kind of GI tract protection. And we do have hard time sometimes to keep them on their H2 blockade. And for the patients who have gastric cancers that, just have a surgery, many times they do a neoadjuvant therapy with ICI, reduce the tumor, get the surgeries, they are on PPI. And I have quite a handful of patients who develop ICIN after that, and they have to be on the PPI because they have recent surgery for a few weeks. And the good thing is that higher dose prednisone, I'm not worried, but I'm worried mostly when I'm tapering, and then they gonna need some therapy. And that's why when I probably would use, if the patient recur with the ICIN, some infliximab to help out with the management as well.
maybe I can comment on the PPIs and oncology. I think that oncology patients are roughly 90% on PPIs for various reasons. And I think oncology is unthinkable without PPIs. So we recommend them for many cases, and we had drug-drug interaction issues like posaconazole for leukemia treatment, where we skipped this, and we had lots of problems because famotidine is the only drug left on the market, which is an H2 blocker. Others were taken off the market, and they have other problems, and I think lack of efficacy if you really want to have acid suppression. So, and patients are getting like gastric ulcers, gastritis, lots of problems, reflux, and most of them are on PPIs, and I think the association is there, but I don't think this changes our practice actually to use PPIs on a broad term.
Yeah, Sandra, that was really amazing. And I was just wondering, it's kind of a now frequently recognized problem. So why are there no randomized controlled trials actually?
For the treatment and management, you mean?
Yeah.
Yeah, I think the bottom line, resources and funding to get a multi-center study. I think that's is a goal to be done. But as you can recently might be aware, funding has been a problem. I don't know if this is a priority for NIH, even though we think it's important, and I think that's supposed to be done. And we were trying, but funding is a main issue.
And it will not get better under this new administration, I guess.
Yeah, I didn't want to comment, but if this is a free place, yeah, it's gonna, like, we don't know what's gonna happen. I myself, I have sent them trials, and I just recently sent. I don't know what's gonna happen. Unfortunately, I don't think this is priority. But it's an important question.
And another one, so you've shown very nicely that in the nephrotic syndrome field, of course, minimal change disease is the most frequent lesion you encounter if you perform a biopsy. And this is not, let's say, very surprising, but on the other side, if you look at the nephritic ones, ANCA vasculitis is pretty surprising that this is probably the most associated glomerular lesion with ICI use, and that's kind of surprising. And the second thing, and I don't understand that either, is that most of these patients are ANCA negative. Do you have any explanation for that?
Yeah, I don't know if it's just because we cannot measure. If it might be there's a pulse immune, there is endotheliitis, vasculitis. We just cannot use the usual measurements. It just might be that we need another type of barrier to measure, but it is surprising, but I don't think it's exactly the same trigger. It's something different. I hope you can find out maybe what you're the specialist in ANCA vasculitis. But it's interesting that usually the ANCA negative, maybe it's just because we are not able to measure them, it's the same pathology. We do have, just my own experience, the only cases that I had are patients who really had some delay or persistent use of ICI and not followed up very closely, or people didn't believe they have AKI because of the ICI. One of my patients stopped taking prednisone because they could not sleep and then developed endotheliitis, and another patient had vasculitis. So I think it's not very common if you're really in the top and can get the treatment right away. But if you delay, it's like, I think it's the platinum, I think it's something, and you don't appropriately treat those patients, they have a higher chance to develop vasculitis.
You mean that something coming later on? Or you first have an ICI-related injury, and if it's not treated well and lasts long, then it can develop vasculitis.
the case that I have, like one was the patient had AIN, was right away found like AKI. The oncologist already treated prednisone. We didn't biopsy because it was the thing that he was using. But it was very in the beginning of the process. So with the amount of creatinine, like next week, creatinine was baseline. And whoever saw the patient start giving ICI before the final treatment. When the prednisone was in higher dose, it was fine. But patient, it was an elderly patient, could have a lot of issues with sleeping. He stopped, like, I cannot sleep. And then he came with full AKI, renal replacement therapy. He was so severe, even with high dose of methylprednisolone. We even give an AKI to the patient, and he became like a comfort care. He decided, I don't want to do dialysis. He was old, and but even though he was palliative, he started making urine after an AKI, but obviously we didn't measure creatinine after that. But and the other similar case was kind of delayed. I think it's a process. If you think a patient AIN, some patients have to be treated right away, otherwise they develop some type of worsening lesion like vasculitis.
So I think we are at the end of an academic hour full of very nice studies. Thank you, Sandra, for your great work in this field and for moving this forward, and also involving us Europeans in your journey. That is really amazing, and we're very thankful for your work.
Thank you. If you give me a chance, if you are interested in onconephrology for the community, we have our next symposium done here in Mayo Clinic in September. We would be happy to have you. It would be nice to see you again, Andreas and Gunnar, and oncologists are also welcome.
And September is a good month to visit Rochester, I guess.
Yes, it's still a nice month to come here. Even though with the weather change, I had snow one time. It was cold for 2 weeks, like -20, but since now I have a long time in Brazil during my holidays, I didn't get much of winter, so it's nicer now.
Yeah,
So we
Professor.
will try to join you later this year. Thanks so much again to the two of you, also to Jörg, for joining us. Have a nice evening, a nice afternoon. See you hopefully quite soon.
Bye-bye.
Bye.
Bye.
Bye.